Thank you for that introduction, David. It's certainly a pleasure to be here in London at the Sixth World Congress. I noticed everyone's showing buildings today, so to clear up any confusion, this is not the Shard. This is the Veterans Affairs Medical Center in Durham, North Carolina, USA. And then across the street from us, this is the entrance to Duke University Hospital. A little bit of business, required business to get out of the way. I have been funded by the Department of Veterans Affairs Office of Research and Development, and a couple of the studies are included in my presentation today. And also, although I do work for the U.S. Department of Veterans Affairs, I'm not speaking on behalf of the U.S. Department of Veterans Affairs. So with that, let's turn to what I want to talk about today. Before talking specifically about teledermatology economics, I'd like to introduce some general economic concepts. Now, I realize most, if not all of you, are familiar with these concepts, but I do want to make sure that we're all on the same page before I turn to the literature. So I'm going to be talking about, defining the economic perspective, different types of economic analysis, sensitivity analysis. Then I'm going to look at some examples of different types of economic analysis in the literature, and then provide a brief overview of the store and forward and real-time teledermatology literature. So when we talk about economic perspective, what we're really saying is who's paying. The societal economic perspective is meant to capture all costs. So it includes costs borne by the healthcare system, by the patient, by government, by private enterprise, and any other affected entity. However, the healthcare system itself often is only interested in those costs that it will bear. So for example, in the Department of Veterans Affairs, they may want to know how a particular intervention is going to affect its own budget. So that would exclude things like out-of-pocket patient expenses, loss of productivity due to loss of work, and other similar costs. An important point about perspective is that you should always choose the perspective when you're designing a study. You should always state the perspective when you're authoring a study. And then, of course, always look for the perspective when you're reading a study. The four most common types of economic analysis are a cost analysis, a cost minimization analysis, a cost effectiveness analysis, and then a cost benefit analysis. And I'll talk about each one of these in turn. So a cost analysis, as the name implies, is really only concerned with the cost of an intervention. By definition, it excludes any consideration of effectiveness or benefit. And this might be relevant when you've made a decision to deploy a particular intervention, and you may want to know, as planned, how much is this intervention going to cost us? Or alternatively, how much of the intervention can we afford? So a cost minimization analysis differs from a cost analysis in that it does not exclude a consideration of effectiveness, but rather it's used when effectiveness is either known to be or found to be equivalent. And of course, if you have no difference in effectiveness, then cost really becomes the driving force in decision making. The term cost effectiveness analysis unfortunately gets used as a generic term for any type of economic analysis, but it really has a specific meaning. It combines a cost analysis with an effectiveness measure. And effectiveness measures are, of course, things like time to intervention, clinical course, quality of life, quality adjusted life years, among others. By definition, a cost effectiveness analysis is comparing two or more interventions. An important point about cost effectiveness analysis is the whole purpose of doing one is to generate incremental cost and incremental effectiveness between your competing strategies. And so this is just a fictional example, but let's say that we find that the average cost per patient for teledermatology is $75, $35 for usual care. Of course, the incremental cost of teledermatology is then $40. But teledermatology might get you to a time to intervention in 5 days compared to 25 days for usual care. So your incremental effectiveness is 20 days. Your cost effectiveness ratio is just simply your incremental cost divided by your incremental effectiveness. which in this case reduces to teledermatology costing $2 more per day of intervention saved. And when you do have differences in cost effectiveness, there's 4 possibilities. So teledermatology compared to usual care could be less costly and more effective. And if that's the case, we would say that teledermatology is the dominant strategy. In that case, you actually don't need to generate cost effectiveness ratios because it is the dominant strategy. More often you get something where teledermatology might be, or a particular intervention, not necessarily teledermatology, might be more costly but more effective. The cost effectiveness ratios are very important in that situation. Teledermatology could be less costly but less effective, and generally that's an unfavorable situation. It kind of depends on how less effective it is. And then finally, teledermatology could be both more costly and less effective, and if that were the case, we would say that teledermatology is dominated by usual care. Now there's obviously a fifth option here that I'm not showing, and that's when cost, effectiveness, or both are equivalent. So a cost-benefit analysis compares costs with benefits, both of which are expressed in monetary terms. So the benefits can be true monetary benefits, but in healthcare, they're much more often benefits that are monetized. So an example of the latter would be that a monetary benefit may be placed on illness avoidance due to some particular prevention program. And then the last concept that I'm going to talk about before I turn to the literature is sensitivity analysis. Basically, this tests variation across an observed, expected, or reasonable range. An example would be a variation in distance traveled for care. So let's just say that we find that the distance traveled for care ranges from 1 kilometer to 200 kilometers. What a sensitivity analysis will do is look for what's called a threshold value or a break-even point. So your sensitivity analysis might tell you something like this. Teledermatology would be the more costly alternative until the travel distance is 100 kilometers, at which point it becomes cost neutral. And that 100 kilometers would therefore be the threshold value. So that's the idea behind a sensitivity analysis. All right, with that, let me turn to some examples from the literature. The first one is a cost-benefit analysis example performed by Richard Wooten and others. This was actually one of the very first economic analyses in teledermatology, or one of the early ones. This study compared real-time teledermatology versus outpatient consultation. The perspective it took, the economic perspective it took, was societal. It was a randomized controlled trial, and it was performed in Northern Ireland. So the trial itself generated outcomes, some of which were things like in-person visits, patient travel, dermatologist consult time. Those, of course, generated the variable cost of those elements. And then, of course, fixed costs were considered, and these are things like equipment and the cost of telecommunication. The benefits were monetized in this study. Basically, non-referrals were considered to have resulted from an educational benefit that was conferred by teledermatology to the referring clinicians. And so basically, the benefit was the cost of that equivalent training. So teledermatology in this analysis was more costly, 201 pounds versus 48 pounds for outpatient care. The benefit was 69 pounds. Of course, that benefit didn't confer on the outpatient side. So the net cost in this study of teledermatology was 132 pounds versus the net cost of outpatient care of 48 pounds. Obviously, the net cost favors outpatient care in this example. The next study is a cost minimization analysis. This was performed by Aminovic and others. And I think this is actually probably one of the best designed and best presented studies in the teledermatology literature, quite frankly. It compared store and forward versus in-person care. The perspective it took was societal. It was a randomized trial that used decision analysis, and it was performed in the Netherlands. This was a cost minimization study because it assumed equivalence that was based in part on prior data from POC, myself, and others that found no difference in clinical course when you used store and forward teledermatology. So they performed a cost identification and accounting as you always should do in these kind of studies. And in this case, the trial provided data such as consult time, in-person visits required, and obviously other data points as well. The study used a decision model that used Monte Carlo simulation that ran 10,000 iterations of the simulation. Now, to be honest with you, only a fool would attempt to try to explain Monte Carlo simulation with one slide, but here's my one slide. So Monte Carlo simulation is a decision analysis technique that integrates uncertainty around specific and relevant variables. So for each variable of interest, it assigns a range and distribution. So the preventable referrals found in this study was 20%. So they assigned a reasonable range of 10 to 50% around that value and assigned a beta distribution to that range. So what Monte Carlo simulation does during its iterations is it samples from that. So this is just fictional, but the first iteration could have pulled 12% from the sample. The second iteration could have pulled 42% from that sample, and so on through each of the 10,000 iterations. And the final sample, as it pulls from there, would be in a beta distribution. And obviously, you simultaneously do all of this for all your variables of interest that you've put in the model. So once they ran their simulation with the 10,000 iterations, what they found was that teledermatology, the mean cost of teledermatology was 387 euros. You can see the associated confidence interval. The mean cost of conventional care was 354 euros, so the incremental cost of teledermatology was 33 euros. I would point out that the confidence interval includes a negative number, so that represents situations where teledermatology would be cost-saving. Also, teledermatology was more costly in 89% of the simulations, which is another thing that the particular software that they used allows you to do. So they also did a sensitivity analysis around a couple of variables. The two that I'll talk about here are referrals prevented and travel distance. As I mentioned, they observed that 20% of their referrals could be prevented. And so with a sensitivity analysis, what they found was that teledermatology was the more costly intervention until you reach 37% referrals prevented, at which point it becomes cost neutral. So the 37% then represents your threshold value. The observed travel distance was 7 kilometers. The sensitivity analysis found a threshold value or break-even cost at 75 kilometers. So again, teledermatology would be more costly until you reached a travel distance of 75 kilometers. Now, 75 kilometers might be an unreasonable distance to travel in the Netherlands for healthcare, but I can tell you it's not an unreasonable distance to travel for care in the US. The next study that I'm going to talk about is a cost-effectiveness analysis, or was designed as a cost-effectiveness analysis, performed by Dada, myself, and others. This compared store and forward teledermatology to conventional referrals. We actually took two perspectives in this study, a societal perspective and the healthcare system perspective, in this case, the Department of Veterans Affairs. Its design was a randomized trial, and it assessed both cost and effectiveness, and we assessed effectiveness with the utility. So this could also be termed a cost-utility analysis. And the site, of course, was the USA. So again, we did cost identification and accounting. The trial results provided data such as in-person visits, required travel, consult time. And as I mentioned, we assessed utility. Utilities are an assessment of the burden of disease. And the particular method that we used to assess utilities was the time trade-off method, which I'll talk about on the next slide. We analyzed the data with bootstrapping, which is a technique very similar to Monte Carlo simulation. And in this case, we did 5,000 iterations. So the time trade-off is something I'd like to just spend a minute on because it's a very simple but I think very elegant technique. And basically what you're asking your patients is if they'd be willing to give up some of their life expectancy to be rid of, in this case, their skin condition. We used a 20-year life expectancy in our time trade-off. So if someone was willing to trade 2 years of their life to be rid of that particular skin condition they were being referred for, then their utility would be represented by 18 divided by 20, or 0.9. And obviously, the lower your utility score, the greater the burden of disease. So what we found from the healthcare system perspective, conventional care costs $338, teledermatology $308, so the incremental cost savings in this case of teledermatology was $30. From the societal perspective, we found greater cost savings, $542 for conventional care, $460 for teledermatology, so an incremental cost savings of $82. And this difference, this difference in cost was a statistically significant difference. At baseline, our utility values for both randomization groups were 0.90, which is always nice when those are the same. It gives you some sense that your randomization actually worked. And at the end of the study, the utilities for both groups increased with just a very small difference between groups. So with essentially equivalent utility values between our two groups, this cost effectiveness analysis really reduces to a cost minimization analysis where, again, cost was really a driving force with a statistically significant difference from the societal perspective. So these next two slides are a brief overview of the store and forward and real-time literature. Obviously, this is a very simplified version of the literature, and I won't go through each one of these in any great detail, but I'll just point out that the reference is obviously on the left. The perspective that the study took is the next column. The relative cost of teledermatology is the third column, and then the effectiveness measure is the fourth column. And what I think is important to point out in this particular slide is all of these relative costs that are depicted in red are studies that found teledermatology to be the less costly strategy. So in 8 of the 10 studies, teledermatology was found to be less costly. Likewise, when effectiveness is depicted in red, that indicates a study that found teledermatology to be more effective. So when you match up a red relative cost with the red effectiveness, those are studies where teledermatology either was considered to be the dominant strategy or could have possibly been considered to be the dominant strategy. When you look at the real-time interactive literature, it looks a little bit different. One major difference is there really has not been cost-effectiveness analyses performed for real-time teledermatology. So the fourth column is the analysis type, which have all been cost-benefit, or cost minimization. But the relative cost of teledermatology, again, when it's depicted in red, are situations where teledermatology was the less costly alternative. So in 4 of the 9 studies, teledermatology was less costly than conventional care. One caveat about this slide is that a lot of these studies were done sort of early on in the teledermatology literature, at a time when the relative cost of technology is a lot more expensive than it is today. So it's certainly possible that if these were repeated today, that the results might look a little bit different. All right, well, to finish up, I guess the question is teledermatology cost effective? And what I'd say is that question doesn't really have an answer, or at least it doesn't have an answer unless you know 2 other things. And that is the question being posed to a decision maker, and what's the perspective of that decision maker? And let me just make a distinction between cost effectiveness and cost effective. So cost effective, the noun, is simply the values you get when you generate your incremental cost and your incremental effectiveness. So these are the numbers or the values that you get. Cost-effective, the adjective, has been defined as providing good value for the amount paid. Deciding that there's good value for the amount paid really depends on the decision maker making a willingness to pay and a willingness to engage decision that secondarily depends on their perspective and motivation. So what I can tell you in my setting in the Department of Veterans Affairs, the motivation to pay for and engage in teledermatology is really driven by a desire to provide access to a nationwide patient population without a nationwide, or at least nationwide equitable distribution of dermatologists. And because of that, teledermatology is fairly widely practiced in the Department of Veterans Affairs nationwide. And I think the point of all that is that the economic analysis is not the only piece of information you need to make decisions about whether to implement a particular intervention or not. And I think the sentence that the dictionary supplied that uses cost-effective helps make my point. The sentence reads, "It wouldn't be cost-effective to heat the whole building for only 3 people." What I'd suggest to you is your perspective on good value for the amount paid might depend on whether you're one of those 3 people or not. So thank you very much. If there's time for questions, I'm happy to take them.